begging for his life to be saved. 4 medical doctors looked at him and turned him away. 3 nurses did not even treat his wounds. So 118 minutes. That is according to the Professor Akosa report. The long time it took before Charles Amissah breathed his last. And now, those 4 doctors are expected to face disciplinary action alongside 3 nurses. The big question is, what exactly is wrong with our healthcare delivery system from the start up until the end, particularly when it comes to emergency situations? This was someone who had just been knocked down by another vehicle. That person had run away. Good Samaritans had called in the ambulance, and it took them 10 minutes to then drive him to the nearest hospital. And he just kept being turned away until he died. And in all this, no doctor really looked at him and his wounds. But when he died, a doctor just came in, certified that he was dead, and then he was asked to be deposited in the morgue. The family have been livid about the situation, but they hope that a committee report, as we see now, and a promise of action, perhaps will ensure that there is no next Charles Amissah. But if you know anything about this country, you know that this is bound to happen again. Because just in 2018, it happened to another victim. Similar situation, a committee investigated this at the Ghana Health Service, at the time led by Dr. Nsiansari. A committee report, just like we've seen, almost similar recommendations. It appears none of them were recommended, or at least in this case involving Charles Amissah. And now another soul is lost. And for so many people, they can tell you stories about so many unknown Charles Amissahs across the country, around this country, who faced similar situations, were turned away by one hospital after the other until they died. The only difference is theirs did not make the news and there was no investigation. So are we going to wait for the next victim to die under similar circumstance? Will it be me? Will it be you? Or will it be our loved ones?
You take a Hippocratic oath, you say I, and you mention Ajimambedu Akosa, and you swear to do that. That is not the establishment.
The kind of mental torture that these individuals are going through, you have absolutely no idea.
We connect right after these messages.
Charlie, dream I'm nice. I get some serious meeting. Allah, motion. But Charlie, no credit today. Oh, but you relax. Momo day.
Hey, what funny.
Yes, so I borrow small, sort myself out, I pay back. We move. Spoil there. Ah, Charlie, you sure say you pay back? Yes, so that anytime somebody else they need them, Momo day. Be like I for can't borrow some more. Hey, you this boy. Don't go there and disgrace yourself. Allah, motion.
Responsible borrowing be the real flexo for today's needs and tomorrow's dreams. Borrow, sort them, pay back. Momo day.
Son, we are so proud of you for setting up this hospital. I really love those hospital beds and waiting chairs. By the way, did you import them?
No, Dad, I didn't. I actually got them from Kingdom Books and Stationery right here in Ghana.
Wow. We also bought our office supplies, safes, executive desks and chairs from Kingdom, and they gave us expert advice on how to set up our office.
Guys, that makes 3 of us. I also got our sofa and bedroom sets, plus our dining hall furniture for our new home from Kingdom.
Wow, Mom, that makes 4 of us. I usually get my stationery items from Kingdom, and my teacher also mentioned that our classroom furniture was provided by Kingdom.
So there you have it. Whenever you're thinking about setting up an office or acquiring furniture for your home, etc., Kingdom Books and Stationery should be your first port of call. With over 40 years experience in the industry, we stock and supply a wide variety of globally sourced office and home furniture, stationery and equipment. Visit our head office,
Kakweje, also near the Osu Cemetery, Temania Community 4, Takoradi opposite Vijay Mays Plaza, Cape Coast University Bookshop,
Spintex Road near Absa Bank, Atomic Center Point Mall, Winneba University Campus, KNUST, the University Bookshop, and Santasi in Kumasi. You can also visit our shop online, www.kingdomstoreonline.com. Hurry while stock lasts. For further inquiries, contact us on 050-162-0810 or 0302-764-101. Email info@kingdomgh.com. Kingdom Books and Stationery Limited, where quality and affordability is assured. Terms and conditions apply.
Hello, CEOs. Ghana's foremost business platform marks 10 years of leadership impact. Join the 10th Ghana CEO Summit and Expo on Thursday, 28th May 2026 from 9 a.m. to 5 p.m. at the Kempinski Hotel Accra. The summit is themed accelerating Ghana's economic transformation, driving bold reforms through leadership, technology, and industrialization. Tagline: from vision to action. His Excellency John Dramani Mahama, President of the Republic of Ghana, will attend as special guest of honor and officially launch the CEO Government Compact 2026. Highlights include presidential CEO dialogue, masterclasses, panels, brand expo, CEO profiles, networking, and the Ghana CEO Excellence Gala. Registered now at GhanaCEOSummit.com. Call 054-639-1970 or email info@GhanaCEOSummit.com. Powered by CEO Network Ghana in partnership with Deloitte, PwC, EY, GIPC, SIGA, University of Ghana, Media General, and the Multimedia Group. The 10th Ghana CEO Summit and Expo. A decade of leadership impact. T&Cs apply.
Cast your mind back to 2022. The prices were rising. The stress was high. Every liter of fuel felt like a sacrifice. Do you remember who stepped forward first? When others were comfortable with high prices, Star Oil chose you. We cut our own profits so you could keep your AC on, keep your engines running, and keep your life moving without the heavy burden. We gave you room to breathe when things felt tight. Because of you, our star savers, we became number one. Today, the pumps are a battleground. Others are finally cutting prices because they have to. But Star Oil, we do it because we want to. Don't just chase a price, remember a friendship. We were there for you then. And with new innovations coming your way, we are here for you now. Star Oil, still quality and affordable fuels for all.
If you want quality, this be where you belong. Hey, tough, hey, strong. Oh, gonna shout and sing the song. When the sun they hot, syntax no break. When the rain they fall, still no shake. Builders they choose and plumbers they prove. Any project you they start. Every mosquito started run away. Sasso, mi se come tonton preko. Sasso, kum tonton preko. Nani sham ne die e demonstronko.
This advert is FDA approved.
I'm not trying to be a prophet of doom, but who is next? Who will be the next victim of Ghana's failed or failing emergency healthcare system? I have some brilliant, interesting minds connecting with us from home and abroad. Dr. Banda Khalifa. I follow him on X a lot. He shares interesting thoughts. He's a medical doctor, physician, scientist, PhD, infectious disease epidemiology at Johns Hopkins University. Doc, it's good to have you connect with us.
Thanks for having me.
Nana Kofi Kwache is Health Systems and Health AI Researcher. He's also Country Director of Alrum Institute, Ghana. Nana Kofi Kwache, it's good to have you connect with us.
Good evening. Thank you for having me.
And then Sechi Brown Reginald, pharmacist, chairperson of All Young Pharmacists in Ghana. He's also known as the Early Career Pharmaceutical Group. Sechi Brown Reginald, good to have you connect with us.
Kwaku, it's always a pleasure, and good evening.
And then Omar Farouk Mohammed is a health policy analyst, CEO of Crestline Health Solutions, and a health policy analyst, like I said. Farouk, it's good to have you connect with us.
Thank you, Professor.
And then, brilliant. And then in studio, Michael Papani actually has a lot of things to say about this situation. Good to connect with us. Michael, good to have you on.
Thank you, Kwaku, for having me.
So, Doc Banda Khalifa, let me start with you. What exactly is the problem? Why can't we seem to fix some of these basic things? Or is it just that some of the doctors are simply really heartless? For which reason? A patient like Charles Amissah, like we saw, will be thrown around like that for 180 minutes until he just couldn't breathe any longer and died.
Thanks again for having me, and good evening to your listeners. I think you've started a very important conversation, and I've had my own fair share of the emergency care system. So anytime I talk about this, I'm from a personal experience of what I went through when I was deployed as a young medical officer with the Ghana forces to Mali. And then I received an unfortunate call about a very dear person to me had a sudden emergency, and she was moved from one facility to the other multiple times and eventually gave up. So I understand what this means. I think this report shows a number of things, and as clearly indicated, Amissah did not die instantly from the crash, but from a prolonged blood loss. And indeed, he was alive at different points, from the accident scene through to police hospital, Greater Accra, and then to Kolebu. So this says that there's no life-saving intervention that was given at any point of that tragedy. And I always like to go back to the WHO's framework, which says that any emergency care is supposed to preserve life at each point of the chain. And most of the time, as we discuss this, we tend to focus too much on the front line. We tend to focus on the end of the chain. You see, a patient should not be moved from one institution to the other. The idea should be that at each contact with the system, they should ideally trigger assessment, stabilization, and safe onward care. So what is wrong with our system, I would say, is usually the number of missed opportunities we have to save someone, and we end up not doing it. So I think this will be my opening remarks, and I would also like to add that as healthcare professionals, doctors, nurses, pharmacists, you name it, one of our genuine joy is to see a patient recover, is to attend to a patient, whether at emergency or at the OPD, and the person comes back and say, "Doc, thank you. I think I'm getting better." That is one of the most rewarding aspects of the work. So as we go through this and we assess how the system has sort of led people to believe that, health professionals are heartless, or we don't care about patient lives, it's just unfortunate, because the same health professionals elsewhere are delivering an amazing work, are delivering the highest level of standard care. So we should be able to question both the individual, but not end there, should also start questioning the institutions and the systems that has forced health workers to be seen as, the villains in this story.
Yeah. Nana Kofi Kwachi, I wonder what your diagnosis of the situation is.
Good evening again, Kwaku, and good evening to all your listeners and to my fellow panelists. Very nice to meet you all virtually. I think Dr. Khalifa has started us off well in terms of pointing out that it's not enough to assess what happens at the point of in that particular interaction or that particular encounter that the person has with the health system. We have to look at it in a broader context. We have to mind, for example, that even when we talk about issues of culture in a health system or behavior in a health system, rather, culture and context also help shaping that. Now, we also have to, I think a lot of the time when we have this conversation, it is a story about Kolebu and Police Hospital and Konfanoche and Tamale, the major teaching hospitals. But we should actually be interested in thinking about why is that the case? Well, that's the case because if you are somebody in an emergency situation and you happen to need an airway intervention, we saw in the slide deck that the Bedu Acosta committee shared, they showed, for example, some basic interventions that they expected. Airway intervention, for example, one of the most fundamental acts in emergency medicine, only 4% of facilities in Ghana have the capacity to deliver that. And we're talking about facilities below the teaching hospitals. If you look at, for example, the supplies you need to do what we call circulation intervention, only 2% have that. Safe blood transfusion, only 15% of emergency facilities can do that. And if you look at even facilities that have defibrillators, only 69% of regional hospitals, 43% of district hospitals, 35% of other general hospitals. We have other medicines we use also in emergency care, like adrenaline and aspirin. Not even 40% of hospitals in Ghana below tertiary level have that. So what actually ends up happening? People have emergency situations, and the lower level facilities that are supposed to be able to absorb some of the shock are absolutely incapable of doing it. That it's a paper thin level of capacity. So what's happening, instead of them absorbing many cases that they should be able to take care of and only referring the most advanced, most extreme cases to teaching hospitals, everything is being channeled to teaching hospitals. And given the constraints of space, of staffing, of resources, there is a point where they naturally do reach a saturation. And from that point on, it's basically trying to figure out appropriate technology ways of dealing with things. It's a bit of innovation, and it's a lot of effort just to try and make up the gap so that you don't reduce patient care quality any lower than it's already dropped. But if we don't have that lower level shock absorber at the district level, at the regional level, then we shouldn't be surprised that so much care goes to higher levels and that so much of the time they don't have capacity. Because when we talk about no bed, we're not talking about literally a bed to put somebody on. We're talking about not having the right space to stabilize the patient, the right stuff, as I listed out here, to intervene, and sometimes the right staff. People are not available. There's not enough of the specialists, emergency care clinicians, etc. So until we're able to figure out how to mitigate that shock absorber system for the emergency care that's at regional and district level, we are going to continue seeing the worst outcomes of our teaching hospitals. And not only are patients who are going there the victims, but the healthcare workers who work there too, under very, very challenging conditions, where they're expected sometimes to do miracles with nothing. So that's my initial diagnosis, and we can get into it as we go along.
Yeah, I mean, this is such a story that, I mean, for so many people, it gets you angry, because you look at all the things that happen from the stages. And Reginald, you've complained a lot about the healthcare delivery system. From start to finish, it clearly failed Amissah.
Yes, Kwaku, maybe the word complaint is interesting in this case. And my seniors have laid a very interesting foundation concerning this issue. Interestingly, over the last, I'll say since 2000, we've had this issues persisting. For anyone who has taken a very critical look at our medical history or sociology of health in Ghana, you would realize that consistently we have not been conscious about our architecture of emergency care. And what I mean by this precisely is that if someone like Charles Amissah had to go through what he did, even before getting to the hospital, Kweku, the fundamental question we need to ask ourselves is what really, right? What capacity did the bystanders in the first place have? Were they conscious of what was happening to the person in question? That is where the entire value chain of emergency care starts. So you realize that over the period, I've been consistently asking why at the grassroots level, whether in the schools, whether in the markets, whether in the workplaces, in religious areas and all that, we are not consciously ingraining the idea of emergency care in our citizens. I'll give you a classic example. Why should you have a graduate, right? Either an SHS graduate or a university graduate come out without basic knowledge of first basic life support, being unable to even administer CPR, right? These are very, very basic things. If you tie that to what happens in the value chain of this particular case, and like you rightly alluded to, we have one too many. PV Obeng comes to mind when it comes to this particular issue. We've had prominent people who collapsed at some point in the gym and then ended up in certain hospitals. And the argument was that people did not recognize that it was a prominent person who had been brought in and they ended up dying. That is the reality of the everyday Ghanaian, you know? And even when such prominent people, right, ended up in such a situation, what systemic shifts happened, right? You would have expected that these gyms, for instance, would, have defibrillators after such an incident has happened. But no, we went back to sleep as a country. So it tells you that there's a behavioral laxity or lethargy when it comes to the entire ecosystem of emergency. And for me, the Charles Amissah debacle was only evidence of a mirror that we have always refused to look in, basically.
Really interesting. Farouk, I want to hear from you, then I'll come to Papani, because Papani has some interesting thoughts on the blame games and things that are going on. But I want to know what you think about how we've gotten here.
Thank you very much, Kwaku Asante. Good evening to you and your service. And good evening to my co-panelists on this show. So, the day before yesterday, listening to the very good professor, Professor Badu Akosa, put forth his report. One thing kept circling around in my mind. I felt, as someone who has worked in another healthcare system other than that of Ghana and run proper triads in proper accidents and emergencies for years. The first thing I learned in other places, in the UK, for example, where I went, I noticed the bed is the last thing the patient needed at that time. The first thing the patient needed was to be sorted at the door. Charles Amissah didn't die because Accra ran out of bed. He died because nobody at any of those three doors, the three hospitals, Rage, Police Hospital, and then Kolebu, was deciding who should be inside the door in the first place. And this is what I mean by that. It wasn't the fault of the workers. Nurses complain they are tired. Doctors complain they were tired. They do complain about these things every day. So, in my opinion, these things didn't kill Charles Amissah. It was a system that sent 50 million people to the wrong door that killed him. I mean, the workers are the last line of defense in a system that failed 3 steps earlier. It is not really a bad problem. I mean, walk into Kolebu, the A&E at Kolebu or any other A&E in Ghana on one evening, and then you notice the cases there are not really trauma cases. These are not cases of strokes. These are not cases of people needing airway management or anything. These are people with rashes, people with mild fever, people with cases that can be handled at the lower level of our healthcare. But these people are very much overcrowded in our A&E because our system is not designed to segregate what goes into the A&E and what remains at the grassroots level. I mean, I still maintain that our system failed Charles Amissah. Our system has failed a lot of people in the past. And as you said, I won't be the prophet of doom, but I can say on authority that it will keep failing people until we get the right things done.
Yeah, very interesting. But Michael, so the system is manned by specific people, institutions. So you look at this particular story. They talk about how for 180 minutes he was turned away by doctors and hospitals who just didn't want to see him. And the view is that the ambulance team quite did their job, or to a certain extent did well, and that the doctors who refused to offer treatment to Charles Amissah ought to take a big part of the blame. I wonder where you stand on that.
In perspective, I think that 180 minutes maybe is difficult to digest. It's 2 hours. 2 minutes away from 2 hours. So that is how much time we are talking about here. From the time around 10:32 when the ambulance service says that they picked the gentleman up. And at the time they transported him to 3 hospitals. So it took 2 hours for all of this to play out. 2 hours, Kwaku. 2 hours. Somebody traveling between here and Takrady would not even have gotten to that destination and their person would have died. And by the way, his sisters were, Amissah had 2 sisters that are work in an emergency situation almost every day. So you can imagine what happened. Our mainly focus, as your question is, that on the first point of contact, right? And I like how the conversation is progressing and the conversations in the media, but I'm thinking that one key thing really is missing from my point of view. It is the first point of contact, which is the ambulance service. And I'll read directly from the report as presented by the committee, unless, of course, somebody has reason to doubt the content of this particular report. This particular one talks about the key findings. It says that Charles Amissah died of excessive loss of blood due to his injuries. I mean, it goes on to talk about the specific injuries, and I'm not sure that, I mean, some of us will understand that. And myself, I'm just struggling to find where exactly these injuries will be found. But clearly means that, Kwaku, those injuries, if they had been responded to in whatever situation or form, would have greatly improved his situation and given him more time beyond 2 hours until he died. Again, excessive loss of blood. It means that if we stopped the blood flow at any point in time, we would have bought Charles Amissah more than 2 hours. The report now goes ahead to, at some point, talk about the fact that if there had been an application of compression on the laceration and packing of deeper wound, all just in saying that if they had applied compression or put pressure on the wounds during transportation in the ambulance, Charles Amissah would have survived. This is the report from these eminent individuals who went to do their own research. No interference by talking to every single person in the chain of command that night. Kwaku, if we had done just these 2 things, Charles Amissah will be sitting here in this chair to give us his expert opinion about what exactly can change about this failing medical system as we have it. After hearing this story, Kwaku, I only ask myself one question. So, what use is it to me if I live? And again, bear in mind, this happened in Kwame Nkrumah's circle, in the middle of the city. In fact, I think that's one of the, why we say unfortunate, but one of the things that anybody in his room have said was fortunate for him, that you are in the middle of all the major hospitals in Accra when you're at circle. So how was it possible that it happened? If you, given where you live far away in the bush, If you called an ambulance and they came, see how long it would have taken them first of all to come. And if they came, they would have just transported you as though you were some delivery parcel that they were just going to give to some hospital to work on you.
Papa is still. So the ambulance officials did not do the compression according to the report. That would have stopped a bit of the blood flow.
Mm-hmm.
But it took them 10 minutes to move from Kwame Nkrumah Circle to the next hospital.
10 minutes, Kwaku.
And
in 10 minutes, they didn't touch the body.
Okay, good. So, but in 118 minutes,
no, Kwaku.
If a doctor, one second, I'm coming.
I get where you're
I'm coming. Let me ask you the question. Your mic is not on. So let me ask you the question. If the doctors had seen Charles Amissah would have been alive. Because, the ambulance officials, they don't apply compression and other things to stop the blood. I'll go to the doctors and Nana Kofi Akwa who knows a lot about this. But they still took him to a hospital. So if they took him to Ridge, I suppose, which is much closer from Circle before maybe police hospital, and Ridge officials just took him in, they could have gone to police hospital straight from the ring road, and they took him in, just dress the wound, make sure that the blood stops. Charles Amissah is alive and is home by now.
Again, you have jumped the chain, right? That the first point of contact, and again, don't forget, if I met you in a dark situation on the floor, my first point of call is to check on you. If you were dead, there was no reason to try and give you CPR or call the ambulance. I'll call the police instead, right? But if the person that attends to you first comes and just picks you up, and I mean, I've read other stories where they talk about sitrep from the ambulance service, where they talk about the fact they check his vitals, and they did. The report captures that. But beyond that, checking your heart rate, Kwaku, for someone who was bleeding that profusely, if they checked his pulse every 5 minutes as they claim, they would have seen that the guy's pulse was falling drastically. And one of the most important things was to stop the blood flow. If you didn't stop the blood flow, and I dare say that, then that means that our ambulance services are just equal to trotros and the taxis that people just jump in and put people's bodies in when there is an accident. There's no difference in waiting for the ambulance service to drive all the way and come to you and come and pick you and transport you, that how the taxi drivers and the trotro drivers will transport you anyway.
That's interesting. Dr. Banda, I wonder what you think about it, because this is important. Our ambulance service must be fit for purpose. And in the world you live in the US, elsewhere, where first responders and first responding does work quite better, ambulance service much more trained, much more equipped to be able to deal with some of these emergencies, to give that person a little bit of a fighting chance as they get to the hospital. Of course, in the US, I doubt it will be turned away like that. But at least, like Papani has said, the kind of compression that was supposed to be applied on the wound to stop the bleeding or to minimize it would have been done. I wonder what you think about that sequence.
Yes, I think that is exactly what is been described. And as I rightly said, anytime we talk about emergency care, we tend to skip all the chains. And per the framework that has been recommended by WHO, you start from pre-hospital. Pre-hospital is one of the crucial points in the chain. Most emergency care or most patients who are suffering from emergencies would have a fighting chance if pre-hospital is adequate, right? Because if you're having, let's say you're having a major bleed, or you're having a heart attack, or you're having a CVA, your first point of contact, the EMT team, when they come around, what they are able to do is what will eventually give you a fighting chance. So it is a real issue that we have to look at. But going back to your issue of system versus individual, I think when we say a system failure, we don't necessarily mean the individuals are innocent or the frontline workers are innocent. It means that individual accountability may not be enough in such a system. If, for example, one nurse or a doctor fails to act, that may be an individual negligence. But if a patient is able to pass through an ambulance system and multiple hospitals and still not get the ability to be triaged or stabilized or treated, then we are looking at something much bigger. It's a system that perhaps allowed responsibility to be passed along until the patient didn't have a fighting chance.
And Kweku, so effectively means that the ambulance personnel, right, they had more access to this patient for 118 minutes. And I'm not even adding the 2 minutes.
Farouk want to say something about what you said, then you can come back. Farouk, I want to hear you from the perspective of the things Papani said here.
All right, Kweku, so with regards to what Papani said, I mean, stopping the bleeding was one thing, but I am really, concerned about the fact that our ambulance crew couldn't resuscitate this guy with some fluid, with some crystalloid fluid, some tranexamic acid. I mean, before he had 2 hours. I mean, we are talking about 2 hours. In 2 hours, it's a good time. I mean, I'm concerned our ambulance doesn't have this fluid. Our ambulance doesn't have this tranexamic medication. Our ambulance doesn't have what it takes to stop, hemorrhage. And my biggest concern is why would an ambulance pick a patient and start looking for bed from? I mean, a good ambulance, a good emergency response or trauma response should be that before even the ambulance picks the patient, there should be a bed for the patient wherever it is, because it's a trauma case. The patient is getting there. The patient is not going to negotiate at the desk. The patient is being received. Blood is being handed. Fluids are being handed. People are attending to this patient. Surgeons are attending to this patient, and this is what a good system is. So I was very livid when I listened to the report from the professor. I mean, our ambulance system admitted that they were with this patient for 2.5 hours, and this patient died from excessive bleeding. One, they couldn't stop the bleed as an ambulance crew, and 2, they couldn't resuscitate this guy. I mean, fluid resuscitation or even CPR. I mean, I was very livid when I heard that. But I mean, that is what the system is. And to add something to what Reginald said, I get very worried every day when I pass through the street of Accra, and then I notice very prominent places don't even have a crash cart. Available. They don't have defibrillator machines available around. I keep telling myself, what if someone, collapses here? What happens then? We were all watching TV, some time ago in Parliament when one of the officers there collapsed. It took the intervention of Napo, the Dr. Baumia's running mate to attend to this person. So these are some of the most important things we tend to skip. I get worried. I as a company, I have sent proposals to big companies to tell them, look, it is not safe to have your staff here not knowing anything about CPR, not knowing anything about BLS, and that's what my company does. We can come in, train your staff on BLS, train your staff on how to resuscitate people, but all they tell me is the financial aspect of it. Oh, we've not got budget for that, we've not got budget for that. And it is worrying. Business point of view, I understand, but the human aspect or the professional aspect of it, it really gets me. Our health centers don't even have a crash cart, and that is serious. We should be worried about that. We don't have a crash trolley, and a crash trolley should have fluids. It should have medications to deal with emergency issues.
Nana Kofi Kwachiakwa. So this is a whole systemic issue. Of course, already the Ghana Medical Association, they've come to the defense of their members. Really, that's what they are there to do. They've talked about how they feel like their members are being scapegoated. That is the words of the General Secretary, Dr. Salome, when he spoke to us earlier in the week. Do you think this presents a big systemic opportunity to fix the system? Or as usual, we'll trade blames around the table. Just, I'm not to blame, it wasn't me, do a lot of shaggy stuff. And then we move on until the next time it happens again, then we repeat the conversation.
For me, in my past writing on this subject, I've described it that I actually find the fact that this happens repeatedly with so little kind of an intentional response pretty obscene. I think it says a lot about the state of values around human life and so many other things that in a reasonable country that professes the things it or believes the things it professes doesn't allow this kind of thing to happen. Now, in terms of what we can do, there are several things we can do right now that are tied in even with the government's policy agenda. We know, for example, that as I described earlier, several of these facilities are woefully under-resourced. Some of these problems are solvable by procurement, and we can do some of that procurement intentionally, gradually, but with a plan to meet the real needs that exist out there. Some of it can also be solved through data systems. We know right now that we're working on the Ghana Health Information System, GIMS, the replacement to Lightwave, and that the Ministry of Health is also working on a National Health Insurance Exchange, a National Health Information Exchange that allows systems to interoperate and other things like that. Those are foundational investments, and we should be intentional about trying to build on top of those the kind of solutions we need that can make it so that, as one of the other panelists said, when an ambulance leads difference at scale. But it comes down to the facts and policy, that policy is about politics and politics is about values. So if we say that this status quo is fine, then nothing will change. But if there's concerted pressure, concerted insistence, more public awareness about the fact that it doesn't have to be like this and that there are real options to the table, then we have a chance to really do something that makes an impact at scale.
And Dr. Banda, look at the things Nana Kofi Kwaku has been talking about, really basic, rudimentary stuff. I mean, the idea that ambulance can pick somebody without the idea of which hospital is closest to us, which hospital is having the facilities, the requisite beds and other things to be able to treat this patient, all of that has not been done. And I don't know, it is so frustrating talking about some of these things because they are so basic. Where do we go from here? How do we use this as a turning point to really get to the point where we are not back around this table talking about the same thing?
Kwaku, yeah, I mean, it's unfortunate, right? And as we've gathered to discuss this, there's another person somewhere who is going through the same scenario. Imagine this happening in central part of Accra. Now, imagine somebody in my small village in Ashanti region having a road traffic accident with a similar situation. What would happen? So it's a complicated issue, and I think we have to start from the basics. So we have to, as one of my panelists said, one of the issues we need to look at is how can we create a system that gives people a chance even before the emergency. So let's look at the prevention and the readiness approach. We need more like an emergency care, or we need to treat emergency care as a national safety system. So funding is one part of the equation. Being able to adequately equip our ambulance systems, train our EMT staff on how to deliver basic emergency care, basic life support, before they even transport people to the hospital. At the scene of injury, I think Umar also made one important point. At the scene of injury, what are your chances before even the ambulance comes in? The bystanders, the facilities with no defibrillators, the facilities with nothing, no equipment to actually deliver first aid. How can we make sure that we are equipping people from police to transport unions to volunteers on basic first aid, bleeding control, and safe patient movement? The ambulance dispatch and pre-hospital care is an entirely different model altogether, where we have to make sure that anybody who is being put on an ambulance to be an EMT personnel is equipped with the basic training tools. And the ambulance is also equipped with basic things that can give people a fighting chance. Now, it then comes to the issue of ambulance to hospital handover. This is also important, as Nana Kofi said. We need a consolidated platform. It's more of a technology or IT system where we can see in real time which hospitals had bed availability, which hospital has the capacity to treat what, which ambulances are available, which districts. So these can be very, very important. Without that, the coordination would not work. If you don't have a centralized system where we are monitoring and delivering live updates, this will not work. And of course, at the emergency unit where we always tend to see the face of health professionals, each facility would obviously need an emergency unit reception and triage model where we know exactly what to do. But the issue is that I think one person mentioned it. Our peripheral systems are not helping. Our peripheral facilities are not helping. They are not equipped to absorb the simple emergency. So everybody ends up in Kolebu. Everybody ends up in Ridge. So, for example, if I'm a medical officer or I'm the one in charge of the emergency and I have 7 patients I'm looking at concurrently, and there's an ambulance that comes in with somebody with, an emergency, what am I supposed to do? So we need a system that also equips the peripheries to be able to absorb some of these simple issues. So it's a complex system, but we need to start from the basics. At the emergency, at the accident scene, what are we supposed to do? During transport, what are we supposed to do? At the receiving facility, what are we supposed to do?
Interesting. So we've just been joined by a paramedic that apparently was involved in the transportation of Mr. Charles Amissah now and Mohammed Najid Mahama. Mohammed, please, what do you know and what interventions do you want to make in terms of the conversation as you're having now?
Yeah, all right. I'm Mohammed Najib Mahama. Just to make a clarification, I wasn't part of the transport, but then I work with National Ambulance Service and in charge of EMS training, and we train the EMTs. And I had the opportunity to talk to some of the people that transported this very patient. And I just want to contribute the conversation that is going on in terms of the capabilities of the EMTs in general in National Ambulance Service. So that's what I want to contribute to.
Please go ahead.
And I'm here with another paramedic who is in charge of clinical audit.
So Najib, let's hear from you on the interventions you want to make and like contribution.
All right. So I want to clarify. In the National Ambulance Service, just like in the U.S., I've worked as a paramedic in the U.S. 911, and I'm working with National Ambulance Service. So we do have different categories of EMTs. So in the National Ambulance Service, we have an EMT. An EMT, in terms of what they can do, they're supposed to do basic lifestyle, support staff, stop, control bleeding as in this. And then we have advanced EMTs that are able to do a lot more interventions with time. I'll be able to tell you some of the interventions. So unfortunately for us, the crew that picked Charles, they were all EMT basics, and they were limited as to what they can do. So the injury itself is high up in the axilla where they couldn't tie a tourniquet or something. Obviously, the doctors already contributed. They should have packed it, wound pack and press and all that. So that could be one of the reasons why the patient actually passed, but we don't know. But the thing is, patient was transported alive to police hospital because when there's an accident, that's a police case. In a case like this, need medical examiner and all these things. The first thing for you to do is to go to where they are needed. So they went to police hospital with patient alive. Patient wasn't dead. So let's say the EMTs were limited and they were not able to pack the wound and compress. So let's say they faulted in that direction. But it doesn't prevent any healthcare personnel, be it doctor, nurse, who knows just to come to the ambulance, put gauze whatever you have, whether they are impregnated with tranexamic acid that they spoke about or not, any gauze at all. Just go to the bleeding point, block the artery, axillary artery, and then clock it. That would have saved the patient. That's what I would say. They had the patient, they transported the patient alive, and that is the key point, to reach whoever knows best. So let's say these EMTs were not doing the right thing. They couldn't compress and then put it, control the bleeding. I mean, somebody who knows better could have just jumped in, clock it for them, and get them going to Kolebu. When they get to Kolebu, same way, they had the patient with them, patient pass, they did some CPR for them and so on. So I think to narrow in and say that the time they had the patient, I mean, we all agree they should be able to, block an artery. But the EMTB in National Ambulance Service in Ghana, just as elsewhere, they are very, very limited. Their length of training. Yes, an unfortunate thing that we didn't have advanced EMTs. So to say they don't have basic life support skills, I don't know. If they don't, that is right. That is bad, they should, because we've given it to them. If they have forgotten, that's a problem. But then to go ahead and say they don't have ACLS skills, I mean, an EMTB, the standards, is not supposed to have ACLS skills. They don't have ATLS skills, they don't have to have it. They cannot give TXA, tranexamic acid, can be given by a paramedic, or even the US, TXA is only given by a paramedic. So in Ghana, we do have handful of paramedics. About 6 of us are in Ghana. We work with the service, support it, train, and we assist. So generally, I think the blame can be shared, throughout, because patient was sent to all these hospitals alive, and patient is still bleeding. And I mean, you know how to pack the wound and compress. That's what we expect.
Yeah.
But now currently we have just introduced a training on it, and we have been training. So on Tuesday we are going to Northern Sector. We are mobilizing all our EMTBs to train them on wound packing and other refresher programs. Which, so in a nutshell, this is what I want to contribute.
Yeah, Najib, thank you very much. That is very informing, and it's good perspective as we prepare to one another. Najib, thank you very much. I'm sure the team will reach out to you again. We need more information. We need more understanding of the good work you and your colleagues are doing at the National Ambulance Service. Thank you very much for joining us. As we begin to wind down, Reginald, I wonder where we go from here. What kind of lessons should we draw from this? Dr. Banda has given us some lucid thoughts about what we do. But for somebody who seemed very frustrated about a healthcare delivery system, writing about it a lot of time, what lessons should we be drawing from this so that we can see it never again?
Yes, Kwaku, sincerely, right, I want to add this before I proceed to prosecute the brief assignment you've given me. Now, Kwaku, this report, right, took its time to enumerate the names of specific nurses and then doctors at the various institutions. Now, finding 7 categorically states that the team, right, in the ambulance crew were inconsistently taking the vitals of the patient. And then they also lacked basic life support, advanced cardiac life support, and then advanced trauma life support skill. My genuine curiosity is why, if in the interest of equity, right, the names, for instance, of the human resource of the ambulance crew was not categorically also mentioned, because the finding 7 raises very critical questions that needs unpacking. But I'll digress. Where do we go from here, Kwaku? We need, first of all, a national campaign on our psyche or understanding of emergency care. Here, a patient should not, or a Ghanaian should not on any day wake up and say, I have an issue, I'm heading to Kolibu. The Ghanaian does not understand how the health system works. So if an issue should arise, the system where the first point of call is very critical. But even before that, as Dr. Banda alluded to, the pre-hospital intervention is super critical, which is why I would humbly recommend that we start a national campaign. For instance, we can start with the State Transport Corporation, or STC. There we have videographic elements in their buses. I don't see why we cannot record basic life support video or tutorials for travelers. At least the first 10
most
5
times
minutes.
we are showing some Lewen movie in the transport.
Exactly. You know, before we start the entertainment, why not do a public announcement? Like when you are on a flight, the first 5-10 minutes, you are giving some very critical information. We can start these little steps, and that's built into the psyche of the Ghanaian. What to do in such cases, the CPRs, the basic life support. Even if people are not having certification, they understand what they need to do when such an incident happens before even the ambulance service kicks in. Then when the ambulance service comes on board, Kwaku, I think it's a serious indictment for us to be able to publish a report and say that our ambulance crew did not have. I could understand if they didn't have advanced life support, but BLS, basic life support training, it raises serious questions that we need to be able to answer. And then finally, this drive of running our emergency system on procurement basis. We have said times without number, Kwaku, how many the essence of having a coordinating system. I remember when the 2018 issue happened, the likes of Occupy Ghana raised this issue, and their seminal recommendation was that we have a national emergency dashboard such that we can have a command center that would coordinate when these things happen. And we should have timelines, and that is where accountability kicks in. When an issue like this happens, what number do you call? How many minutes do we expect the response to kick in? There you can hold people accountable.
Yeah.
And then also in the
Reginald, I know you have a lot to say about this, and this is a conversation we'll come back to. I really apologize that I have to cut you. Andy Dusty is up next, of course, with the library. Thank you very much, Reginald, for joining us. Interesting thought, as always, that you share on this subject. Dr. Banda Khalifa, as always, really grateful that you joined us to share your insights on this. And Nana Kofi Kwache, I follow you on X. You are one of those that very, very passionate about our nation and some of the things that we can do to get to this point. So thank you very much for joining also. And then Omar Farouk Mohammed of Crestline Health Solutions and Health Policy Analyst. You also joined, and then earlier on you had Papa me. So that is how we wrap up the show. Tomorrow on Newsfile, this subject will be discussed. 118 minutes of neglect. Who killed Amissah? PDS arrest, NAFCO arrest, oral in flight, and press freedom, the scorecard on a JM 2.0, or with Samson Ladanyanini at 8 a.m. on Joy News and Joy FM. In just about 5 or 6 minutes, you start hearing from Andy Dusty on the library. Today, there's going to be a lot about the TGMA that is happening tomorrow. Me, I've told Andy already. Tomorrow's Artist of the Year should be Black Sheriff. I'm hearing some names. Please. Next year, they can try. But this year, no one honest enough about this would say someone else should win this other than Black Sheriff. I'll see you again, same time next week. My name is Kwaku Asante, and Andy Dusty.